Madam Deputy Speaker, and I'd like to start off by saying that Healthwatch in Calderdale, like Healthwatch organisations across England, are the voice of people in their area on health and social care matters. They also tell NHS service providers and commissioners about patients' experience of care, and they hold them to account as well. And they also have a say in how local services are delivered and designed. Now, Madam Deputy Speaker, as a very rough rule and guide at Healthwatch Calderdale, a trigger to indicate there is a particular issue in an area of health or social care is when it receives about 3 complaints on the same issue at the same time. You can imagine then the concern when Healthwatch Calderdale began to hear of difficult NHS experiences from a large number of adults with hypermobility syndromes, both at events and via its telephone advice service. So much so that for the first time since inception, a joint piece of work was undertaken between all local Healthwatch areas across Yorkshire and Humber, with Healthwatch Calderdale taking the lead. Approximately 250 adults with hypermobility syndromes took part in the project, all relating stories of difficult NHS care. I'll speak more on the findings of the report shortly, but first, an outline of what hypermobility syndromes are. Hypermobility is the term used to describe the ability to move joints beyond the normal range of movement, something I haven't been able to do for many, many years. But joint hypermobility is common in the general population, especially in childhood and adolescence, in females, and in people of Asian and African Caribbean descent. In many people, joint hypermobility is not problematic at all. It can even be a bonus, especially if you are a sportsman or sportswoman. However, the debate tonight is neither about athletics, nor is it about party tricks. It's about problematic hypermobility linked to chronic ill health. It's about people who experience symptomatic hypermobility, not just affecting the joints, but also causing very challenging symptoms in many other body systems, including the digestion, the nervous system, the skin, the bladder, the cardiovascular system, teeth, and of course the immune system too. It is these people who are described as having hypermobility syndrome. The most common of these hypermobility spectrum disorders, the most common of these is hypermobility spectrum disorder. Other conditions include heritable disorders of connective tissue such as Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta, and Stickler syndrome as well. Whilst these are all conditions in their own right, all are very complex, chronic conditions frequently associated with comorbidities which require multidisciplinary healthcare teams for the diagnosis, for the treatment, and for the management. It'd be a pleasure to.
Thank you for giving way, and thank you for bringing this matter to the House for the adjournment debate and consideration tonight. Does anyone remember not agree that the feelings of people suffering from hypermobility syndrome is that they have to fight to be believed, fight to be seen, fight to be diagnosed, fight to receive treatment, and they are tired of simply fighting? And does anyone further agree that the NHS in Calderdale, and indeed in further afield, must simply do better to believe what is happening, and therefore they must also treat these people?
My honourable friend is absolutely right in a lot of what he says, but the thing about hypermobility syndromes is that they can be and are incredibly complex. So as I said earlier, things like digestive system, immune systems, teeth are all factors in some of these things. So it's not like if you go with a broken leg, you know what the problem is. There are many multiple complexities around this disorder. So it is difficult from a professional point of view, which I'll speak about a little bit later on as well, but you're absolutely right in much of what you say. What I will say from the Healthwatch work on the subject, it is clear that many people, specifically those with hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder, are not receiving that appropriate NHS care, as my honourable friend from Strangford has already indicated. It is not clear how many people in the United Kingdom are affected by hypermobility syndromes. Hypermobility is often misdiagnosed as fibromyalgia, osteoarthritis, stereonegative arthropy, physiogenetic rheumatism, depression, or chronic fatigue syndrome 2. Now, I don't know about you, Madam Deputy Speaker, but after that description, I need to lie down in a darkened room. So imagine how, then, the patients with hypermobility-related problems feel when they have to battle alone with immense health problems, quite often for years before obtaining a diagnosis, only then to face the immense difficulties in accessing appropriate NHS healthcare to manage their complex and multi-system disorders and conditions. These patients describe feelings of being let down by the system, as well as huge frustration at both the widespread lack of understanding about their condition from medical professionals and the lack of appropriate care for their condition. It would be an honour to give way to my neighbour.
I'm highly grateful to my honourable neighbour for giving way and thank him for his work in securing the debate this evening and congratulate him on articulating a number of those medical conditions incredibly well. I have two constituents that I'm aware of who have a diagnosis for Ehlers-Danlos syndrome. And I was incredibly disappointed earlier this year when the CCG informed me that the Manchester Royal Infirmary, who had been delivering a degree of care for those with hypermobility, had been in a position where they were going to have to stop accepting tertiary referrals for that support. So not only are people struggling to get that diagnosis after years, what we're finding that regionally that specialist care is also then just not available once they've received a diagnosis. And that is something that we really do need to address.
My honourable friend and neighbour from Halifax is absolutely right in what she says. The problem is because there is a lack of understanding about these syndromes, and because not only at GP level but in some specialist areas too, in those areas where they do particularly well with this issue, they are now having to close the list to outsiders because they're becoming oversubscribed in the areas they are. So you're absolutely right. It is one of the issues. And hopefully when I get to the end of my speech, one of the recommendations, hopefully to the Minister can hopefully address, is about something around having a regional centre for this particular issue. So on to the report, Madam Deputy Speaker. The report was published in July this year, and it focuses primarily on patient experiences. It presents the overwhelming negative NHS experiences of adults with hypermobility syndromes, and it does make for challenging reading. It's 70-odd pages, and it's not a pleasant read at all. Now, the report took evidence from 252 people via focus groups and a questionnaire. Approximately 86% of the participants had a diagnosis of hypermobile Ehlers-Danlos syndrome, or what would now be termed as hypermobility spectrum disorder. A further 13% had other diagnoses linked to hypermobility syndromes. It is precisely these people who are presently excluded from NHS specialised rheumatology services. It is these people on who I would like to focus on this evening. The report identifies problems with NHS care in many different areas. In terms of diagnosis, the report highlights that people are experiencing difficulties obtaining a diagnosis. 76% of respondents indicated that obtaining a diagnosis had been challenging. 22% described the process as difficult, and a staggering 54% stated it had been very difficult. Frequently, people describe the diagnostic process as leaving them feeling depressed, alone, and isolated as a consequence of the lack of understanding that appeared to be the norm amongst professionals. This and the level of disbelief, as my honourable friend from Strangford pointed out earlier, the level of disbelief by professionals also led to people doubting themselves despite their symptoms and, of course, their experiences. Common terms to use to describe how the diagnostic process made people feel included angry, belittled, desperate, feeling like a liar, a fraud, and some even said they were feeling like they were going a little crazy. In contrast, obtaining a diagnosis generated feelings of hope, of reassurance, and feeling that they'd been vindicated or relieved at having an explanation of their difficulties. On the road to diagnosis, many tests and procedures were commonly performed, sometimes repeatedly, sometimes in isolation, and sometimes in conjunction with others. Many people had reported that they've had many blood tests, many scans, and many x-rays. A number of respondents spoke of being tested exhaustively over many years. For some people, this extensive testing was a route to eventual diagnosis, and in some cases, supported interventions. But for others, this resulted in delaying the diagnosis, misdiagnosis, and delayed support. A pathway would not only be beneficial to patients, but it would also reduce the costs and associated wastage to the NHS of all the unnecessary tests, which are often carried out on a repetitive basis as they are not giving the anticipated results at the time. Participants reported that between 1 and 6 health professionals were involved in the diagnosis. One significant theme of the responses generally is the failure of medical professionals to link together the variety of symptoms and health issues being reported, and the focus on the presenting symptom only. Perhaps unsurprisingly, many participants said that they had received other diagnoses rather than a diagnosis of hypermobility syndrome. Altogether, a staggering 62 other conditions were named during the process. The complex and diverse symptoms resulting from hypermobility syndromes has led to many people being misdiagnosed and being told, for example, that their symptoms are related to mental health issues or mental illness such as depression, anxiety or stress, and resulted in subsequent referrals to mental health services as health professionals could not find a physical cause for their symptoms. People also reported that health professionals had ascribed the symptoms to excess weight, clumsiness, or lack of physical exercise. Misdiagnosis, partial diagnosis, or stereotyping left people feeling upset, patronised by health officials, and also led to feelings of anger, frustration, dejection, and defeat. Inadequate knowledge amongst health professionals was another key theme of the report, and that also emerged from the data. The majority of respondents referred to health professionals either as not aware of, not knowing about, or not believing in the wide-ranging symptoms and the health and life impact of hypermobility syndromes on the patients. GPs were specifically mentioned in this regard. Rheumatologists and physiotherapists, I should say, received mixed feedback in terms of their knowledge too. Some people who had a diagnosis also talked of medical professionals disbelieving the conditions, some being told it's all in your head, or assuming people were just after drugs rather than generally being in pain despite the diagnosis. Another key theme that emerges from the data is poor communication between health professionals, both between departments in the same service and also between one medical facility and another. Communication between professionals is by no means consistent. Communication failures occur frequently and conversations are repeated at consultation. And again, this experience, as described, is exhausting and demoralising. A number of participants also reported difficulties in persuading their GPs to refer them to consultants. Most people who responded to the survey stated that they had either no NHS care or they had inadequate NHS care. The life impact of these difficult NHS experiences is significant, with people having to give up work, experiencing difficulties in education, problems with social relationships, the breakdown of families, and also financial problems too. Of course, I'll give away.
I thank Alexander for giving way again. He's outlined the cases for the people physically, emotionally and mentally. Does he also, or is he aware that it's not just that as well, it's a follow-on? When you can't work, you need benefits, you need help. If the doctors don't understand the intricacies of the health condition, then how can they put it on paper to back the constituents' claim for benefits whenever they don't understand it either? Does he sometimes become bewildered with the system?
I think it's not particularly me that becomes bewildered with the system. I think it's the patients themselves who are incredibly frustrated at the whole process. And like you say, it's not just pre-diagnosis, but it's also post-diagnosis as well, where the lack of professional understanding, unless you are lucky enough to get a good consultant or a good GP that understands the system, then some of these things go on for years. The frustration, the pain, the stress, the anxiety, all those things that we've already spoken about. So my honourable friend from Strangford, again, is absolutely right in what he says. But ironically, people feel that they have to manage their own cases entirely without medical support, sometimes without fully understanding it themselves, researching the condition so that they can then ask for what they think they might need. This was often stressful for the respondents, the stress causing further problems for these people. Some people spoke of having some NHS care, but for some people the only care they received was pain management, often without review. There are several examples of respondents being prescribed opium or strong medications, but they said it was without adequate medical support or review as well. In the few cases where people reported having good experiences, and there were some, of the NHS care, this appeared to be generally after moving around the country, changing GPs or hospital specialists, and this usually occurred over a long period of time too. It should be noted, I will say, that not many people commented on social care experiences, and this in itself may, there's no evidence, but it may reflect the lack of involvement and awareness of the issues among social care staff too. A few people have received some care or support via social care. Most frequently reported were aids and adaptations at home. Some people have also been given additional support around personal care and social support as well. But, Madam Deputy Speaker, the report details exactly what actions all of the local Healthwatch organisations in Yorkshire and the Humber will do and will take on to raise these issues with local NHS service providers and commissioners. But, Madam Deputy Speaker, what is it that those who have experienced this poor level of care in the report, what is it they're asking for from government, NHS England and our strategic health authorities too? Well, I've gone through the common asks, but I've come up with 5 which I think are probably the most important. And not just me, but what the authors of the report think are probably the 5 key points as well. So first of all, they're asking for improved knowledge and awareness of hypermobility syndromes and the related conditions amongst health professionals across the whole of the NHS. Secondly, they're asking for a dedicated care pathway with faster referrals and a specialist service of some form, such as a specific regional specialist centre. This, people felt, would help to address the current fragmented care that many people are receiving. Thirdly, they're asking for the ability to access medical support when needed for services such as physiotherapy without the need for a new referral. Each time a course of physiotherapy is required, currently they have to go back through the process again to get that and be referred. Fourth, they'd like to see the use of technology such as video or telephone appointments to access medical professionals. This would help people better manage fatigue by removing the requirement to physically be present at the appointment. And finally, improved communication, coordination and information sharing between health and social care, either as part of a specialist service, as we've already discussed, or simply just as good practice. Now, Madam Deputy Speaker, some of the above suggestions regarding better care, such as digitalisation and integrated care fit very well already with the NHS long-term plan. It is very clear, however, that other additional actions are required to improve that NHS care for this group of patients. It is important to remember that the vast majority of people who responded to this Healthwatch Hypermobility Syndrome survey are not those who are referred to the specialised rheumatology services, which is commissioned by the NHS England. They have hypermobile Ehlers-Danlos syndrome, or what is now known as hypermobility spectrum disorder. They are specifically excluded from the Ehlers-Danlos National Diagnostic Service and at present have very poor experiences of those NHS care, which, they report, impacts incredibly negatively on the lives. Can I thank you, Madam Deputy Speaker, for your time this evening, and can I say I look forward to hearing my friend, colleague's response.
Minister Joe Churchill.
Thank you very much, Madam Deputy Speaker. If I may, I'd like to congratulate my honourable friend for Calder Valley on securing the debate on such an important issue and for taking that first step for bringing that broader element of education and communication to the Chamber here tonight by outlining to the Chamber the report from Healthwatch Calderdale on hypermobility syndrome, and to join him in commending the work of local health watches in championing the patient voice and doing all that they do. My honourable friend has rightly highlighted how critical it is for those living with hypermobility syndromes to be able to obtain the right diagnosis, and sometimes how challenging that is because of the nature of all the different elements of the syndrome involved. Now, it is also to have their symptoms taken seriously by healthcare professionals, as both he, the Honourable Member for Strangford, and the Honourable Member for Halifax outlined. It's sometimes just being taken seriously is the first step on that path to accessing the relevant treatment that you need. Now, those professionals need to be aware of the spectrum of the condition, and all of these things are incredibly important so the patients can access the right care at the right time. For example, accessing physiotherapy if you are feeling particularly unwell and then feeling like you have to go back down the snake can often seem more of the fight that the Honourable Member for Strangford alluded to. So making sure that pathways are streamlined is exceedingly important. As my honourable friend will be aware, NHS England's specialist commissioning team in Yorkshire and the Humber responded to the report only last month, and I gather that the specialist commissioning team and CCG are continuing to engage with Healthwatch Calderdale on the report findings. Ensuring that that engagement is actually beneficial and delivers what patients want, and that it's as broad as possible, is important. And I would urge both the Honourable Member for Halifax and for Calderdale to perhaps make sure they are engaged with the process and holding the CCG and Healthwatch to account in actually understanding whether objectives are being met and better service is being delivered. Madam Deputy Speaker, we've heard from my honourable friend that hypermobility syndromes can have devastating effects on quality of life, but often go undiagnosed or misdiagnosed for many years, which again adds to the stress. This situation must improve. As my right honourable friend pointed out, good communication and information sharing could make a lot of difference to how an individual actually feels their journey is progressing. I want to assure my honourable friend that we are committed to improving the diagnosis of rare diseases and to assist patients for which a diagnosis, as my honourable friend for Strangford said, feels less like a fight in itself. Of course.
Whittaker.
I'd like to thank my honourable friend for allowing me to intervene again after taking up so much time. But one of the key problems that we see is that the hypermobility syndromes are treated by NHS England as rare diseases. And as we've heard, I mean, just 11 cases in Calderdale Healthwatch that are currently on the books as being complaints. If you times it over Yorkshire and Humber, there are several hundred cases where people have complained. And that's people that have only complained and not actually been diagnosed. So my challenge back to the Minister would be, we keep calling it a rare disease, but actually, is it really a rare disease?
Thank you, Madam Deputy Speaker. Rare diseases, the challenge with rare diseases are that they are collectively common, but rare in and amongst themselves. As the Honourable Gentleman articulated himself, there are many different elements of this particular disease and syndrome that may be diagnosed as Ehlers-Danlos, may be diagnosed as a plethora of other things, and that actually makes treating them more of a challenge. And it's why there has to be a degree of communication and shared information to actually make it a proper pathway for an individual. Although 11 complaints, and to each of those individual lives, it is really challenging. That is not a large patient cohort. And that is one of the challenges when you're dealing with diseases and syndromes such as Ehlers-Danlos and hypermobility syndromes more broadly. So improving the diagnosis using cutting-edge technology is key, and the Genomics Medicine Service was announced last October and aims to provide consistent and equitable access to the most up-to-date genomic testing in England, which may indeed help. I am pleased that hypermobility syndromes are included in the National Genomic Test Directory, which underpins this service, which may give more of the cohesion that my honourable friend is looking for. As my honourable friend points out, improving awareness of hypermobility syndromes amongst healthcare professionals is key to what we've been discussing here tonight, particularly general practitioners. It's critical to ensure better diagnosis and treatment of these conditions. It's vital if we're going to build trust and confidence in the system to actually help those with rare diseases. As I say, they're collectively common, with 3.5 million people across the UK affected. But despite this, there is a significant gap in our understanding of the way that many of these diseases actually begin to be able to be diagnosed because of the number of different ways in which they can present themselves. In terms of raising awareness, there's always more that can be done, and we must learn from areas of good practice. For example, Ehlers-Danlos Support UK has developed an Ehlers-Danlos Syndrome EDS toolkit in collaboration with the Royal College of GPs. And I'm pleased to hear that in my honourable friend's local CCG, NHS Calderdale, has issued the links to the EDS toolkit to its GP member practices. It has also encouraged clinicians to consider adding this topic to their learning needs, because building awareness is very much part of the answer. Recently, a clinical update on Ehlers-Danlos syndromes was published in the BMJ. Another excellent example of how the clinical community are working to improve knowledge and awareness and help provide positive NHS care for patients by transferring that knowledge into better diagnosis. NHS England commissions specialist diagnostic services for hypermobility syndromes, including Ehlers-Danlos syndrome, osteogenesis imperfecta and Stickler syndrome. NHS England is currently improving and implementing a new rare disease insert, which aims to improve the patient experience through the provision of a single person responsible for the coordination of care for hypermobility patients, which I think is one of those asks that very much his constituents was worth asking for. It also aims to improve the transition pathway from child to adult rare disease services, including for those with hypermobility syndromes. There are several centres in England delivering services for hypermobility, and as the Honourable Lady for Halifax alluded to, not all of these are always accessible to everyone, but they do include 2 centres delivering complex EDS services, 4 delivering osteogenesis imperfecta and childhood osteogenesis imperfecta services, and a specialist centre for Stickler syndrome. These centres help to coordinate the specialist regional care and manage transition into non-specialist NHS care. And I did very much hear my honourable friend's request for a more coordinated service for his constituents, and I would encourage him to engage with his CCG, as the idea has much merit in order to better diagnose and give a better pathway for patients. Potentially discussing the single point of contact for patients, giving them that much needed continuity and the sort of timeline that they feel it will be arriving in the Calder Valley and to patients more broadly. Virtual GP services was another interesting area that my honourable friend said he thought would help the particular people with hypermobility syndrome, because it would stop them having to travel all the time. And he will be pleased to hear that the virtual GP services in general practice are beginning to be rolled out, which will mean that patients have the right to web and video consultations by April 2021, something else that hopefully will benefit. As was announced by my colleague Baroness Nicola Blackwood this summer, we need a national conversation on rare diseases to help inform and help to communicate, and we will be engaging with patients, researchers and clinicians, gathering evidence and identifying the major challenges faced in this field. We would really welcome the input from the hypermobility syndrome patient cohort and healthcare professionals and the work that they've done on this report. So in closing, Madam Deputy Speaker, I would like to thank my honourable friend who has spoken so passionately and so knowledgeably about this issue. I am very grateful for such an important report to be discussed in the Chamber tonight. We are dedicated to trying to improve the life of all patients living with hypermobility, and this is laid down, as my right honourable friend said, in the NHS long-term plan and our implementation of the UK strategy. So tonight, I hope I have reassured a little those patients who are struggling for diagnosis that we are here to try and make those pathways stronger, diagnosis easier, and improve the lives of all those affected by hypermobility syndrome and other rare diseases.
The question is that this House do now adjourn. As many as that opinion, say aye.
Aye.
The ayes have it. The ayes have it.